So hi everyone. Um, we're going to just vamp for a minute while we let people arrive. But tonight, our webinar is on back to school essentials, speech and language edition. And tonight, we are going to be talking about speech and language therapy and how it is used to help kids with special needs excel and do their best and be successful. Uh, for those of you who don't know me, my name is Elizabeth Errico. I'm the Executive Director of the Children's Mental Health Resource Center, and our mission is to provide guidance and resources for the early identification and management of mood disorders, bipolar disorder, and its newly identified phenotype, which is called fear of harm, or FOH for short. And at CMHRC, we do a lot of work to fulfill this mission by providing services to families, to schools, to providers, and practitioners within the fields of mental health and education. We do this work through our diagnostic consultation service, which we do for families as well as for providers. We have a school advocacy for mental health, where we work with families to ensure that their children are getting the IEP and 504 plans that they need and the accommodations that they require to be successful at school. We have a community advocacy program for mental health, where we work with families' existing providers, with their Cub Scout troops, with their extended family, or anyone that they need help and support around communicating their mental health needs with. We have our web app, which is called the CMHRC Toolkit, which allows individuals to track their symptom presentation, their moods, their medication management and compliance, as well as even the weather in their where they are. And we have a version of this for providers, where they can work with their patients to share data on how their patients are doing. We are also working on a new version that is specifically for schools to be able to communicate with families across settings. We also have transition support, which helps families when they're moving from one place to another or needing to change providers for some reason. We do all of this as an organization that is by, for, and about families living with mental health disorders and challenges. With me tonight is Jennifer Sevick. She is our clinical coordinator here at CMHRC. And joining us for our conversation tonight is speech and language pathologist Bobbi AdamsBrown. I'm going to end this screen share now and invite Bobbi to introduce yourself and share a little bit about what you do with our audience.
Absolutely. Let's see. Here we are. So I've titled this What's Going On and How Can I Help? Because I feel like that's kind of where everyone ends up. Something's going on. I don't really know what it is, but I want to help. So what do I do? And I'll be discussing kind of a foundational understanding of neurodiversity, language, and support services. So we'll definitely be getting to all the things that you discussed. So here's a little quick bit about me. I am the speech language pathologist and CEO for Anchor Creek Speech Therapy. My background is in speech language pathology and audiology, but I also have a background in elementary education. And some information about me more personally is I do identify as neurodivergent, which is one of the things I'll be explaining briefly. And I also was a primary caregiver of my autistic sibling for many years. So I feel like I had the interesting experience of being every seat at the IEP table at some point or another, as a speech pathologist, as a teacher, as a caregiver. And I know all seats at the table are stressful, in part because everybody's just trying to figure out what's going on. So we'll get a chance to talk about that. So to start, I want to discuss a little bit about terminology because it's going to make the rest of what I'm talking about make more sense. So here's a little Venn diagram. You heard me mention before that I identify as neurodivergent. There are these three terms that come up a lot, and sometimes people aren't really sure what they mean. So neurotypical is a person or a group of people who have the more common brain type. They're kind of the type of brain that everything else is being compared to. So that's called neurotypical and sometimes shortened to NT. Neurodivergent is a person or a group of people who have neurological differences when compared to the more common brain type. It doesn't necessarily mean disabled. It's not necessarily a problem. It's just when you're comparing the brain types, they're not the same as the more common brain type. And then neurodiverse is a group that has both neurotypical people and neurodivergent people. Sometimes you might hear people saying, oh, this person's neurodiverse. If it's not a group, then neurodiverse isn't the term because it's talking about different brain types. So what are some examples of neurodivergent? Some examples, including but not limited to learning differences, being autistic, ADHD, mental or emotional differences, dyslexia, acquired neurodivergencies like PTSD and long COVID. Of course, some of these fall into some of the other categories named, but just some examples of, these are brain types. They are types that aren't the more common brain type when you compare them. And so the brain type is different. A person can have multiple neurodivergencies. They could be just one, they could be more than one. For example, many autistic people are also ADHD. A person could be ADHD and dyslexic. A person could be bipolar and have PTSD. There are all these, you're not necessarily just one. And that's why neurodivergent is kind of the catch-all term, especially since many neurodivergent people have a couple of different things that are noteworthy about their brain when you're comparing. Go ahead.
Can I ask you a quick question? This is fascinating to me, and I'm listening to you describe neurodivergent as a category, and I'm thinking about the statistics that we know about the prevalence of mental health challenges in our population. That 1 in 5 Americans at some point has a diagnosable mental illness, and that's just mental illness. And I'm wondering, when you start layering on acquired neurodivergence, learning disabilities and differences, who doesn't fall into the category of neurodivergent? I mean, it really seems like everyone I know is in that category.
Well, and that's the thing, and that's why I put more common brain type in quotes for neurotypical, because especially when you consider the different types of neurodivergencies, I would say being neurotypical is actually way more uncommon, because I mean, who among us, especially after the pandemic, doesn't at least have some anxiety,
Right.
But it's more that one brain type is the one that other things are kind of judged against, and not necessarily that most people are that. That's just what people think is more common, if that makes sense.
That makes so much sense. It really does make so much sense. It's neurotypical almost seems like an idea of what the brain should be rather than what is most commonly or typically the brain.
I would say so. And, another thing is not only, and this is kind of a side note, not only does neurodivergency often run in families, but also because of neurotypes, people tend to be more likely to bond with people with a similar neurotype. So social communication styles are similar among neurodivergent people. So sometimes, and I didn't get into this in the presentation, but just as an aside, sometimes people think that, for example, autistic people have like a lack of social skill, when actually there's a type of social skill, social norms that are common up among neurodivergent people, that if you didn't communicate that way, it would be odd, but it's just based on where we as a society place more value on
Hmm.
the type. So yeah, that was just an aside. Sorry about that, but I feel
No,
what you
thank you
mean.
for
Oh,
saying that.
I was saying that often, especially when one person gets diagnosed, like their whole cluster of friends and family tend to get diagnosed, because we tend to link more easily with people who just communicate similar to how we do. And so
Right.
it's not uncommon to see these ripples as it goes through. Anyway.
Makes sense.
So I will generally be using the term neurodivergent through the presentation. And if I'm talking about a specific neurodivergency, usually autism, since I just work primarily with autistic people, I'll specify it, but there are a lot of things that are common among just being neurodivergent generally. So I'll use neurodivergent in those cases. So um, I won't make you show me, but another quick acknowledgement about language. If you could, anybody who's watching, using stick figures, at least in your brain, try to show the difference between a person with autism and an autistic person. You can use symbols, you can use shading, you can use colors. Everybody kind of take a moment in your head or with something nearby to show the difference to you between a person with autism and an autistic person. So I'm just going to give a few seconds for people to draw this mental picture or physical one. Okay, so like I said, I won't make you show me, but here is one that someone else has done. So person first language, here we have person with autism, they're holding a bag, right? The bag is the autism, right? We have on the spectrum, where has this person just standing on a spectrum of colors. And then we have autistic person, where we see that the shading of the spectrum, as it were, is in their head, right? So person first language is like the bag, and identity first language is like the shading in the head. Identity first language is when you put how someone identifies first, not the word person. And I'll get into why that is. And here I've left the website of the person who originally made this little graphic, because I just thought it was so helpful in trying to conceptualize, because sometimes people think it means the same, and there's a little bit of nuance. So person first language tends to be preferred by non-disabled or neurotypical people. It's often used in education and healthcare, and it implies that the person is a person first, the disability is second. Identity first language tends to be preferred by autistic and other disabled communities, and it implies the person cannot be separated from their disability or difference because it's part of who they are. So, of course, people may have individual preferences, and how they prefer to be referred to is what you should default to. And also individual communities may have a certain preference for person first versus identity first. I'm going to be sticking primarily to identity first, saying autistic person, not person with autism, or neurodivergent person, not person with neurodivergency, just because that tends to be what the community prefers, especially because well, it's not a handbag. So we're talking about just a way a person's brain type is. So the last terminology side note before diving in, there are some people, and this isn't all going to be about speech. I'm going to talk about some other things too, but there are sometimes people think that speech and language are the same thing, and they're not quite the same thing. So communication has a few different parts. There's receptive language, and I tell people all the time, you don't have to remember the difference between these, only that that there are these different categories. So receptive language, how I usually demonstrate it whenever I talk to families, is what you understand. Expressive language is what you use, so what words you use to communicate. And it could be mouth words, it could be sign language, it could be AAC. And speech is the sounds you use to communicate. So you can have a speech sound problem and not have any language problems. You can have a language problem and not have any speech sound problems. Typically, people say speech therapist because it's shorter than saying speech language pathologist, but really, language is a larger aspect of what SLPs do. And so I'm going to be talking about things like language, and I just wanted to clear up kind of the difference between the understanding, the use, and the sounds of it. So when should you pursue testing? Now here, whenever I'm saying testing, it could be testing regarding language skills. It could be any kind of thing. What are some signs that maybe some testing should be pursued? Whether that's just figuring out if there's maybe a problem going on, and or if they might have a different neurotype. So I generally say if a person is having a difficult time or is feeling frustrated, frequently frustrated, it's worth it to investigate why they are frustrated and if there are any supports that could be in place. So some more well-known signs that a person may benefit from an evaluation are things like having difficulty communicating. Like, so sometimes people say, oh, if they don't have 50 words by the time they're 2, or if they're not combining 2 words by the time they're 2, that kind of thing, then maybe you should look at getting tested. Difficulty being understood when they communicate. So they're saying something and it doesn't quite make sense, might be worth pursuing testing. Speech sounds come in a certain order. So having problems with R's at 3, not really an area of concern. But, in this presentation, I'm not assuming that you are a speech therapist watching this. I'm assuming you don't know what all these norms are. This is whether or not you should even look into something, right? So if they're having difficulty communicating, worth it to get it checked out to see if there's something that might be helpful.
Bobbi, can I just ask how do you compare these things to developmental stage? Because I'm listening to you talk and I'm thinking to myself that there may be a child who's comfortable not speaking, and so they're not experiencing frustration, and there may or may not be some sort of pathology to their not speaking, or they may just be comfortable that way. So how do you assess that in terms of a 2-year-old versus a 4-year-old versus a 10-year-old?
Yeah. So really it comes back to if they're frustrated, if they're having a difficult time getting their point across, getting their wants and needs known, really at any age. It might be worth looking into. And um, you know, the thing is, when frustration levels increase, language use decreases. So sometimes people think, oh, they might be too comfortable, and so they're not frustrated. And because they're not frustrated, they're not communicating. But
Hmm.
actually, being really frustrated makes it harder to communicate.
Sure.
So it's um, inherently, you're going to have some level of frustration if you can't get your wants and needs known.
I have a
Mhm,
question.
mhm,
Um, what happens in early childhood when a parent is telling a doctor, "Hey, I have some concerns. My child isn't cooing, making sounds, making noises, isn't
mhm.
like expressing a first word," and the doctor is saying, "Oh, Mrs. Smith, but every child develops in their own time and their own way. Let's wait and see." For a parent who's really concerned about that and they're getting the wait and see response, what would you suggest to a parent?
I would say um, going in with some key examples of where you're seeing it, and sometimes being specific about who you want an what kind of professional you want an evaluation from. And I'll go into some of the areas and some of the professionals that can help depending on it. But um, ultimately, as I discuss later, a pediatrician is a generalist. They're just taught when to refer, but just because they're taught when to refer doesn't mean that they always know that it's a situation to refer. They're just taught generalities, you know. It's kind of like a dentist can have a lot of training and not be able to fix my broken toe, you know. There are different specialties that are out there, and um so I definitely recommend continuing to pursue, because nothing bad happens from getting checked. Like, uh you
That's a
know
great
there
phrase. I'm going to use that.
well, and I think sometimes doctors try to be reassuring, right? Like everything's probably fine. And then there's also sometimes a limit of resources, not enough speech therapists, not enough occupational therapists, among other professionals. And so I think sometimes doctors try to slow it down by not sending over everybody, but nothing bad happens from getting checked. And no one can be the professional, like no parent and even no doctor can know all of the things. It's just better to refer out to people who are trained in it. Um, so another well-known sign that a person may benefit from an evaluation is difficulty answering questions, right? Whenever parents tell me that they could tell something was going on, they say, oh, I ask him questions but he doesn't answer, or they talk but I don't understand what they're saying, or he doesn't have that many words, right? That tends to be the signs that make parents pursue it. But there are some less well-known signs that parents should still pursue getting some testing done. um, Seeming to be able to communicate but not when they're frustrated. um, you know, for neurotypical people, they may still have access to their language, even if it's not as good as their language when they're not frustrated, but still have access to their language and their mouth words, even when they're pretty frustrated. But many neurodivergent people, particularly autistic people, when their frustration level gets too high, they can't communicate with mouth words, particularly. And so, if we're seeing that they're able to communicate sometimes, but when they start to get really frustrated, they can't, then we go, hey, is there something else that might need some support? Not necessarily that it's wrong, but if they're struggling to communicate when they're frustrated, then that's a good time, for me as a neurodiversity affirming speech therapist, to train the family on how do we work around the fact that there's this blockage when the frustration levels get too high, right? What other ways can we help them communicate, or how can we change what we're asking or doing so that they're able to let us know things even when they don't have access to those mouth words?
So that makes sense to me, because
Mhm.
with the families in our community that we work with who live with mood disorders, when they get frustrated is when a lot of professionals like teachers or whoever's working with them expect, like, use your words, tell me what's going on,
The
and then
worst.
they can't and they shut down. And then I see a lot, Bobby, where the goals for therapy when you're working with a psychotherapist is like,
Mhm.
one of the goals is to be able to communicate effectively. So I'm interested as the night goes on, like your thoughts on how do we support the child and how do we support them when those things are happening?
Yeah, absolutely. I think that we are on the same wavelength there, and it's definitely something I've seen too. And I'll definitely be getting to that too. So, some other less well-known signs: speaking in sentences, but difficulty expressing wants, needs, or problems, or sometimes that they're saying something, but what they're trying to communicate doesn't always line up. An example that I can think of off the top of my head was a kid I was working with, and we'll talk a little bit more about this later. But an example is I was doing a Zoom call with his mom. It was his first time seeing me, and I was just talking to mom that day, and he kept coming over to mom. What you doing? And mom would say, "Oh, I'm talking to Miss Bobby." "Well, you do it." "I'm talking to Miss Bobby." "Well, you do it." And so it was like this loop where mom thought she was answering his question, but, and he was speaking in a sentence, right? But I helped mom realize he wasn't actually asking her what she was doing. Typically, when grown-ups are talking to like 2-year-olds and saying, "What are you doing?" they're usually getting in trouble and they're telling them to stop doing it. So he was like, "I don't know who this lady is, and I want you to stop." And he kept saying, "What you doing?" And mom kept answering the question, thinking that he was asking, but he wasn't. He was trying to let her know, "Hey, quit doing that. Like, I'm ready to play with you. Why are you talking to this lady?" Right? And so that's an example of speaking in sentences, but what he's trying to express and what he is saying aren't quite lining up. Seeming to get frustrated out of nowhere. That's one I hear a lot. Like, "Oh, he was just throwing things out of nowhere, right? Everything was fine. And then he was yelling, or she just, threw her toys, or she, ran at the wall and it was out of nowhere." Generally, that doesn't happen out of nowhere. Now, it may not be as perceivable from the outside if you don't know what to look for, whether it's something about the situation or something sensory, or even, being asked questions that you don't know the answer to, and you don't know how to express that you don't know the answer to it, and you just want people to stop, right? But people often say, "out of nowhere." That's a good sign to get things checked out, to figure out where is it actually coming from, because nobody likes being frustrated. Um, Difficulties with changes in schedule or routines. Again, this isn't inherently bad. It is common among some of the neurodivergencies, particularly among autism. And so there are ways that we can provide supports if there's difficulty with changes in schedule or routines, and not every parent or professional who's unfamiliar is going to know what those are. So that's a good time to get evaluated to see if that might be beneficial. And also a less well-known sign, because I know some of the people who may be watching it are people whose children uh, may talk a lot and seem like they're doing well, but they're always waiting until the last minute, or they're so forgetful. And that can be related to executive function, which I'll discuss a little bit later, and some of the more complex language skills. So always waiting until the last minute is not something people tend to do for fun. It is common among certain neurotypes, and there are supports for it.
Bobbi, we have a question here from someone who's asking about the term selective non-speaker, or perhaps selective mute. Those were the two terms that she used. How does that relate to what you've been talking about?
So, sure. So, having situational mutism or situationally non-speaking, that tends to be related to, I mean, it's not uncommon among autism. It can also be there's a lot of different neurotypes that it can be related to, in part. Anxiety can be one of them. And there are still supports in place for that too. So I think, sometimes people wonder if seeing these things necessarily means something's wrong. It may not be that something is wrong, but it may be signs that there could be some supports that should be in place. If you have a different neurotype, or even if there's just a language delay, there's just no reason to be so frustrated when there are supports that could be in place, because when you're regulated, when you feel connected, when you have ways that you can communicate and express things, your quality of life is going to be better, first and foremost. But two, I mean, it's just easier to learn more things, and just everything gets better. So it's not necessarily a lack of skill, but sometimes it's a sign that there might be some benefits of some supports.
There's one other question that I want to share with you, and then you can sort of decide when it's most appropriate to share the answer. But we have a mom here who's saying that she has a little one who's going into pre-K and is acting out with a lot of big tantrums, throwing toys, and doesn't use words to express. And she's concerned, understandably, that the school is going to label him as a behavior problem. And she's wondering what she can do to partner with her school to ensure that that doesn't happen. She does mention here that he's getting some speech therapy sessions over the summer, but whenever that's appropriate to answer in the context of your presentation, that would be great.
Yeah, absolutely. And I would say regarding that, sometimes, and we'll discuss this a little bit later too, sometimes we have to help the professionals that we're connecting with see some of the patterns, because professionals too are often trained as generalists and have to choose to specialize, particularly whenever it comes to neurodivergency. And so, some of the things that we'll end up speaking about later are, some of the areas where you might want to seek some supports, and who should be getting involved for that, but also sometimes where testing doesn't paint the whole picture. And so I would say that's an example. I would say generally, I try to always encourage people, if everyone's thinking that someone is being bad, and I know that this parent is not saying that, but the parent expresses concern that the school team might perceive it that way. To try to look for some patterns in what's happening, to see where that frustration level is escalating from, because those are definitely signs that some support needs to be in place, because nobody enjoys throwing tantrums. like it feels bad. And that's why there's this saying, kids do well when they can do well. So if they're not doing well, that's a sign that they need some sort of support, whether that's with a skill, whether it's adjusting expectations. And so if they're struggling, that's a sign that there should be some supports. And sometimes we have to help our teams see where those things could be, because it can be easy sometimes to jump to the conclusion, oh, they're just bad, or oh, they're just lazy, or oh, they just don't like sharing, without taking the time to figure out what's really going on.
Thank you.
Yeah, absolutely. Some misconceptions that parents have prior to evaluations. So before an evaluation has taken place, sometimes when parents are debating whether or not to pursue an evaluation, or some things that get said beforehand and they're not sure. One that comes up, as you mentioned before, the doctor said he's spoiled and that's why they don't talk. That's just not how it works. Because not talking takes so much more energy to have to express the same idea. Communicating is generally the fastest way to express an idea. So it's not about being spoiled. Sometimes there are some other things going on. And as mentioned earlier, pediatricians are generalists. And so you hope that they know what they're seeing, but they might not, and it's still worth it to ask again, or ask a different doctor sometimes. In the case of my sister, when she was 2.5, we were told that she was just spoiled. She just didn't have a reason to communicate, and that's why she wasn't communicating. And then we sought out more answers, and it turned out that she was autistic. She wasn't spoiled. And then he said, oh, well, she may never communicate, was the jump that the doctor made. And within 6 or 8 months, she had caught up a lot in her language skills with just the right support. But to go from, oh, she's just spoiled, to, I guess she's never going to communicate, really shows the lack of understanding that this particular doctor had. So another thing that families sometimes say is, he understands a lot. I don't know why he doesn't talk. Well, we talked earlier about there is a difference between what you understand and what you use to communicate. So you can have really great understanding and still have difficulty communicating. She doesn't talk yet, so I don't think she could do any testing. Well, there's lots of testing that can happen, even if a kid's not able to participate, including things like parent and caregiver interviews and some observational things. Sometimes parents expect that their child would have to sit at a table to do like paperwork. And clinicians are trained on kids, sometimes younger than 2. We wouldn't expect a 1.5-year-old to sit at a table and do paperwork. So there are definitely ways of still getting information. So-and-so, whatever family member, was a late talker and they caught up. And that could be true. It could be true that she had a cousin, he had an uncle who didn't talk until they were 5, and then everything was fine. But they also don't need to be that level of frustrated. And I have seen kids before who start to take kind of a back seat in their own life because they just feel like they have no way of letting people know things. And so they just are resigned,
It sounds a little bit, you're talking about something that's very near and dear to us, which is the idea that intervention isn't always about, quote, fixing a problem, but improving the quality of life of the person.
Yeah.
And that you find maybe you will catch up later and everything will be fine. But did you have to struggle? And
Right.
if not, why put yourself through that frustration? Why put a child through that frustration and struggle when providing some supports could resolve that?
Absolutely. I mean, couldn't that struggle time have been saved doing literally anything else? Um, like there's just no point. And saying that a person shouldn't struggle doesn't mean that they shouldn't have to learn things. It's not a cop out. It's
Right.
um, you know, do we expect a wheelchair user to use the stairs because they should struggle? No, that's silly.
Right.
And so,
In our community, we hear a lot of, but you're enabling or you're coddling them. And so when we're saying as parents, like, hey, I don't think my child is capable at this moment of learning this coping strategy or this coping skill or how to use their words. And then
right.
the comeback is, but then you're enabling them, you're coddling them, you're allowing them to do continued what they call learned avoidance.
Yeah.
That's just
If
not
I
how that
hear the
works.
I hear the phrase a lot of times, you don't prepare the road for your child, you prepare your child for the road. And I really bristle at that because the idea that there's one path for everyone that has to be followed is so preposterous to me. And why put someone through that trauma, as you said, when they could be doing literally anything else more productive, engaging, satisfying, and nurturing with their time. It really doesn't make sense. So thank you so much for highlighting that.
Yeah, definitely. It's kind of like I could learn to change my own oil, and there are some people who really value that. Couldn't I spend my time another way?
Right.
Sometimes it's beneficial to have some supports and do something else. So um some other misconceptions that people have. He talks all the time, so there's nothing to be concerned about. She makes straight A's. She's super smart. When I tell him not to do something, he just laughs. I think he's just messing with me, but he has lots of friends and makes eye contact. She just has a lot of energy. She won't stop moving. They just hate homework. They're just lazy, but she's been reading since he was 2. Yeah, those things can be true. But if they're frustrated, if they're having difficulty making their wants, needs, and problems known, then it's worth it to figure out why, and if there's any supports that could be in place or any skills that might need to be taught to address why that is. Or even if it's something that should be concerned about. Like sometimes parents are concerned when their child doesn't answer why questions when the child is 2. And me as a speech therapist, I go, wow, that would be crazy if a child was answering a bunch of why questions when they were 2. And it's not the parent's job to know when those things should come in. If the child is feeling frustrated, if they're struggling to express their wants, needs, ideas, their problems, go check it out. And see. So really it comes down to frustration level. So
I
how
like
do I get
how
an evaluation?
Oh, I was gonna say, I like how you included that homework there because we see that so often. And it's not just homework, it's schoolwork in general when it's challenging. And they'll go, but you could do it yesterday, or you funny how you did it this morning. And then all of a sudden now you can't do it right at this moment. Um, do you find that people do that too? Like you could express yourself fine this morning, but then this afternoon you've lost all your ability to do, X, Y,
Mm-hmm.
and Z.
Yeah, and especially for people who, for example, have sensory differences, where if uh, overwhelm is a bucket, right? And things are being added to it all day long, and maybe you have sensory differences. So it's the lights, it's the smells, it's how loud the announcement was. It was a fire drill, right? You started the day with an empty bucket, so you weren't going to spill anything. But as the day goes on, you're starting to slosh over the top, right? And so, yeah, it might have been fine this morning. The bucket wasn't heavy this morning. The bucket wasn't full this morning. How can we make sure that bucket doesn't get full so we can have a good day the whole day long? The time of day can make a huge difference, and the things that happened earlier in the day. So yeah, sometimes people do make the assumption that just because something is easy at a particular time of day or a particular kind of way, that it's something that doesn't need any support. But that's when we really need to look at the situation to see why it's sometimes difficult and how big of a deal is it. It could be difficult certain times of the day and not be a big deal. I don't mow the lawn when it's 100 degrees outside. I can know that it being hot outside is why it would be difficult. I can pick a different time of day to mow the lawn. So it doesn't necessarily, again, mean that it's a problem, but it's worth knowing where the problem's coming from. So how do I get an evaluation for my child? So at any age, you can ask your pediatrician for a referral for an evaluation. You will want to specify the areas you notice your child getting the most frustrated. You might name certain professionals that you would like a referral to, such as a speech pathologist or an occupational therapist. We'll get more into some of the things you might see and who you might want to involve on the next slide. Prior to age 3, there are early intervention programs in the US. They do vary by state. And so depending on the state, changes kind of the pathway you take, but a pediatrician is often involved for the programs that are under 3. And starting at age 3, you can still seek outside services. You don't have to go through the school district, but starting at age 3, you can go through the school district. So even if they're not kindergarten age, once they turn 3, legally, the school district has to provide the service if it's determined that a service is needed. So if they're, 3 or about to turn 3, you can contact your local school district. I usually recommend calling the special education department in your school district's district office. Then submit it in writing, because the timeline starts once it's in writing. But I sometimes recommend calling first just to find out who to even send that email to. Sometimes people, just go to their local school's front office and tell somebody, but sometimes the message doesn't get to the right person. That's why it's better just to call the school district's district office to make sure the right person got the message. But then still submit it in writing, because that starts your legal timeline. So some differences in the specialist you may want to involve. So I am listing just a few, I have 2 slides of it. Some differences you may notice, a little explanation on it. Some of the people who might be involved either in the school district or outside of the school district. So auditory processing disorders, or difficulty processing something that you hear, like you might have perfect understanding when you read it, but when someone tells you, it's hard for you to hold on to it, or difficulty understanding what someone's saying when there's background noise is one of the other ways that you might notice some auditory processing difficulties. SLP, psychologists, and audiologists are often involved for determining that. And who gets involved kind of depends on whether you're going the medical route or the education route. But either way, usually they get involved. Language delay differences, things like late talking or difficulty communicating wants, needs, or ideas. You would usually go to an SLP for that. Executive dysfunction is difficulty with planning, initiating, executing tasks, and difficulty managing attention. So that would often be SLP, psychologists, and OTs. And for many of the psychology ones that I've listed here, they're not necessarily providing the support, but in the school district, they might be involved in doing the assessment for it. For many of the ones that I'm listing here, it would be SLP or OT providing the support and the evaluation services. For sensory processing issues or differences like strong reactions, positive or negative to sensations like noise, movement, texture, or smell. OT and SLP could get involved for that. Particularly whenever it comes to sensory stuff, there's a lot of places where speech therapy and OT overlap. Often when people think of OT, they think of handwriting, which is commonly what it looks like in the schools. Not all OTs are trained in sensory, and not all SLPs are trained in sensory either. So it's more about just finding someone who's sensory trained. A sensory trained OT is a unicorn and wonderful. And when you're noticing a lot of frustration, I always try and get them involved, but they are kind of hard to come by. And so if you can have both a sensory experienced / trained speech therapist and OT, perfect picture. I often in my area have to do a lot of sensory helping families understand and figure out sensory stuff going on, just because I don't have a sensory trained OT in my area to refer out to. And so got to give people some answers and direct them to the right resources, you know? So OT and SLP could be involved for sensory. Related to sensory is alexithymia. That's difficulty sensing physical and emotional state. So OT and SLP could be involved for that. So an example from that would be, for instance, I am ADHD and I have some sensory processing differences, and my alexithymia presents as whenever I am regulated, I'm not too stressed. I can tell when I'm hungry. I can tell when I'm thirsty. I can tell when, I don't know, I'm excited, right? But whenever I'm really stressed, I no longer feel hunger. So if you said, are you hungry? I would tell you no, because if I did a body check, you know, how do I feel? I wouldn't feel hunger. But it doesn't mean that my body doesn't want food. It means I am not reading the signal coming from my body. Even though, as an aside, even though I can train people on recognizing the signals coming from my body, it doesn't change the fact that whenever I'm stressed or overwhelmed, I may still not receive those signals anyway. In which case, even I have to get the supports in place in my environment and come up with plans so that even if I'm not feeling hunger, I will still eat, because my body will still want food even if I don't feel it. So in case anybody runs into that, that's an example. Gross or fine motor differences. That's differences or difficulties with fine motor movements, which is things like buttons, shoe tying, typically things you do with your fingers. Gross motor differences are things you do whole body. That's often involved in like walking, throwing, the big body movements. OT is typically fine motor, and PT is often gross motor. Feeding and eating differences, like not eating certain food groups, textures, or other distinguishing features of certain foods like smells. And it's related to sensory processing or alexithymia. And so OT and SLP can both be involved for that. And apraxia or dyspraxia is difficulties with motor programming for speech and body movement. So you might get SLP, OT, and PT involved for that. Again, this presentation is not on necessarily what all of these things are, but in just kind of bringing awareness of some of the things that you might notice and who might need to get involved based on that. So typical aspects of evaluations. Evaluations typically include things like parent or caregiver interviews. So typically whoever's doing the evaluating, whatever the purpose of the evaluation is, they typically ask you, if you're the parent or caregiver, what's going on, asking you questions about their health, language, and developmental history. There are often also standardized tests. That is typically when the clinician, again, this could be SLP, psychologist, OT, PT, any different kind of professional, where they're asking a person certain questions in a certain order, you might see flip books or pictures or certain toys. And sometimes parents are a little confused because they said, oh, they asked it this way, but if they would have said it this way, he would have gotten it. But for standardized tests, they have to ask it a certain way, because even if they think the child could get it right if they asked it differently, they're not able to use the scores from the test if they ask the question differently. So sometimes parents say, oh, they asked that, but they didn't even show him this, or they didn't. And so, even as professionals, sometimes also hate the standardized test. And especially for neurodiversity affirming professionals, we may only use them if we feel like we have to for insurance or qualification purpose. Because they're very limiting. But sometimes a pair requires it. Language
Bobbi,
samples, particularly.
we have a question here.
Mhm.
This person says, Bobbi, you are magnificent. I'm learning so much. I was wondering what the best words to substitute for the word normal.
I think depending on what you're describing, neurotypical is usually the word for that. So if it's like, oh, he's not doing it like normal kids, neurotypical kids, right? The more what people think of as being the standard, right? Or describing things more like different, not necessarily disordered, not necessarily wrong or weird, but it's just different.
Would you, sometimes I use the word, and I'm curious what you think of this, not expected or unexpected, to describe something that isn't, quote, normal.
Yeah, I think it kind of depends. I think depending on how it's used, sometimes there's a judgment conveyed to it when it depends on who is expecting it.
Well, that's why I
Mhm.
liked it, because I think it puts the responsibility back on the observer rather than on the individual, and saying that my expectations were
Mhm.
X, Y, or Z, and the child's did something different. And
Mhm.
so as a result, it's my expectations that were changed.
Mhm.
It's not a reflection of them.
Right. I think sometimes whenever I'm not quite sure where to label it, I just describe it. I just say what happened.
Yeah.
Because then the person might, it depends on who's reading the report,
Right.
it depends on who's doing it. And for example, whenever it comes to info dumping, which is communication style common among neurodivergent people, where you're sharing a lot of information all at once about a topic, and it comes from enthusiasm and wanting to share joy, right?
Mm-hmm.
Among neurotypical people, that is sometimes seen as selfish, like I just want to talk about what I want to talk about. But among neurodivergent people, it's not perceived that way because it's about sharing joy. I feel
Right.
like if you understood the cool things about this, then you would feel the joy that I feel. And then I'm trying to make you happy by telling you about it, right?
Right.
And so if we said, oh, this child spoke in an unexpected amount about spiders, right? There's that kind of conveying about it could be seen, depending on who's reading it, as being a negative thing. But among neurodivergent people, that would be great. Like I info dump with my friends, and we have a great understanding about it, that it's about shared joy, and there's not an expectation that the other person has to love it, but it's like, I find a lot of joy in this, and now you get to share about your joy, and maybe we'll find joy in the same thing. And maybe we won't, and that's okay.
Right.
So
Right.
describing is sometimes the best way to make the point clear.
Gotcha.
So language samples typically our speech pathologist would do And that's when a child's playing with a caregiver or a peer, sometimes the clinician, and the clinician records it and then analyzes what was said. So for example, if I'm doing a language sample, I might, start recording and a kid has a toy or I'm bringing out a toy or something like that. And I have the interaction where I'm really trying to get a lot of language out of it, right? Because it's not about me asking a lot of questions. It's just hearing about what words they use on their own. And so in recording it, I later type it up and then I can analyze, oh, this is the kinds of questions they asked or the kinds of words they used, or this is what happened when there was a communication breakdown, that kind of thing. And language samples tend to be the better way to go with neurodivergent kids for some reasons that I'll get into momentarily. And last, among other things, tend to be non-standardized assessments, things like checklists, or like, for instance, a parent recently described to me when their child was doing an evaluation with a school district that the OT, the SLP, and I think maybe it was early childhood teacher was also there, and they had certain toys out, and basically as the toys were out, the different professionals were getting different information based on how the child interacted with the toy and what they said. So like the OT was looking at how they did this, and the SLP was looking about how they talked about this, that kind of thing. So sometimes parents see it and they're like, I don't know, they brought out this doll and then I don't know, but different people are kind of looking at different things sometimes in those situations. So where things get tricky. And I'm trying to be mindful of time, so I'm trying to go a little fast through this part, but just to kind of bring awareness to some things that are tricky that you might come across. Getting evaluated is inherently a change to schedule or routine. Many neurodivergent people, particularly autistic people, struggle with changes to schedules and routines. This leads to higher stress levels, often causing difficulty using mouth words, difficulty processing language, difficulty regulating, and so being more sensory seeking or more sensory sensitive than usual. So, sometimes it's in a new place, it's with a person you've never met, and suddenly there's all these expectations about what you're supposed to do. Then everybody has a lot of pressure, right? Because the parent is stressed because they want their child to do the best they can when they're there. The kid is stressed because they're in this new place with a new person being told to do a whole bunch of stuff. And then the person who's doing the evaluation is stressed because they're trying to get this kid to do all this stuff, and the results are unreliable because it's just based on everybody's stress levels during that time. It's an inconvenient truth, as it were, that sometimes what we get to see in evaluation is not necessarily what a person will do. And that's one of the reasons why we try to do, or a good clinician often tries to do some of those other ways. For instance, if I have a kid who's under 3 in particular, I make the assumption I'm not going to see everything. I'm just not, because they're under 3 and I'm a stranger. So I'm putting more of my evaluation on the parent interview and maybe trying to see if I can get the kid at least comfortable enough to play with their parent enough that I can write down some of the stuff they said. But the parent interview and the tests that I use that involve asking parents questions, that's where I'll put more of my reliability, not what I saw when they were there, So there are ways of trying to work around it, but parents tend to be very stressed when their kid's not doing the best they could possibly do, right? And that's where it gets tricky. So another thing that gets tricky, many clinicians are unfamiliar with how to assess people with communication differences. Like many assessments are based on being given a direction, such as touch the ball. And if the person doesn't follow the direction, it assumes that they didn't understand the concept. Like, for instance, there can be a test where it has 3 pictures. It's like a doll, a ball, and a bear. And the, clinician says, touch the ball. Well, this kid has never been in a situation where they had to look at 3 pictures and touch a thing. There's no purpose to it. There's not really a reason to do it. They may not do it, and then the person goes, oh, they don't know what a ball is. But if they had brought out a ball, the kid would have done it fine. You know what I mean? Sometimes they're just in an unfamiliar situation and assumptions are being made based on how they participated, when sometimes the conclusion is wrong.
We we see that a lot with like children being diagnosed oppositional defiant disorder. Because a child in that moment may be having stress, and maybe the evaluators are having stress of like, why aren't they doing this? Or like for a
Mhm.
million different reasons. But the end result is the phone call that I got was maybe from the school setting or from wherever, that child has oppositional defiant disorder. And we think it's a parenting issue.
Uh-huh.
We hear that a lot.
That is such a cop out, you know? I don't know what the problem is, but it's probably you guys. It wasn't me,
Right.
right? Very rude. I get offended on parents' behalf whenever I overhear about people saying that, because it's, it really eats at a parent, especially when they're coming from a place of stress and care, just trying to help. And then a professional comes along and makes a bunch of conclusions, mostly based on you're a bad parent and that's why. It's just not
Yeah.
fair. Anyway. Another thing that gets tricky is many assessments are based on being asked a question such as, who teaches kids to read and write? And if the child struggles to answer or does not use mouth words, it's assumed that they didn't know what a teacher is when they may not have understood the question. So for example, I may know the word for a water bottle in Japanese, but if you asked me in Japanese, what is this? I may not understand your question, even though I knew the answer. So sometimes the issue is based on the questions that are being asked, or how it was phrased. And then especially whenever it comes to standardized tests where you can only ask it a certain way, sometimes only one time, then suddenly it can look like a kid is struggling more than they are. Another example I have is I had a 7-year-old, I've actually had more than one at this point, who struggled with using mouth words because he was apraxic. And he was in a self-contained class, and his mom was preparing for an IEP, and she asked me what things she should ask about in her IEP, and I told her to ask if they're doing literacy instruction. And she said, oh, it's a school, I'm sure they are. And I said, you should probably ask just in case. And it turned out they were not, because they assumed he couldn't read because he didn't use mouth words. And so I talked mom through some stuff. It turned out he could read a lot. Just because he couldn't sound it out with his mouth didn't mean he couldn't read it. And there are ways to confirm that, but they hadn't tried because they didn't know how to check for that for a kid who struggles to communicate with their mouth. So that's another place where things can get tricky. Another place where things get tricky, standardized tests are based on neurotypical language and skill development, and neurodivergent language and skill development happens in a different order. So for instance, with the 7-year-old that I just talked about, if we were going through a standardized test, so a standardized test is when questions are asked in a certain order from easy to hard generally, and the assumption is that they get a certain number of questions wrong in a row, that everything after that they would get wrong. So they won't even be asked anything after that point, because the assumption is, since it's easy to hard, easy, based on the standard that they sampled, that there's no way they could get those later questions right. So if you were giving this 7-year-old a standardized test and you asked, like, does he label animals? Does he ask questions? Does he, think of all the things that would come up before you would get to, does he read? Right? And so scores on standardized tests, particularly on psych and language testing, can be misleading because the skill development can happen in a different order. A kid can test high but still be struggling. A kid could test low and not be struggling as much because it's just based on where the test that was used and what questions got asked in the order they were asked in, whether or not their actual skill set was even asked about.
That makes so much sense to me, because we do in South Carolina, and I'm assuming it's the same like in a lot of places, we do this thing called map testing. Are you familiar with that? And so it's that exact same thing. You are asked certain levels, like 4 questions in a row, and then it's thrown out. But I am familiar with children who have auditory processing disorder. And so what happens when you have auditory processes, and there's different types of auditory processing too, like different subtypes. But the one that I'm most familiar with is like they can do these concepts, but they can't actually break them down. And so they might be able to do like this very complex equation or something hard like in math, but then you give them the simple part, and it's almost like it's a new problem and they don't understand it because they had been doing the hard part for so long, and it's just developmentally not in the sequence that they're used to doing. So for me, that makes sense of like these tests are designed for somebody who is considered a typical learner rather than someone who is a diverse learner.
Right. And, you know, I've had kids that I've worked with who can read and spell and do multiplication when they're 2, 3 years old, but can't tell you that they're thirsty, that they can't tell you something hurts, or, you know, answer some of the questions that you ask. And that's why we can't say someone is low or high, because the order is different. That's why we have to really ignore the numbers and focus on the areas where the child is frustrated or struggling. So even though I might have this 2-year-old who can read books and do multiplication, does that mean that I shouldn't help him tell people that he wants water because he does multiplication? No, these things are different. Like, where is he frustrated or struggling? Let's look at that instead. So another area where things get tricky is neurodivergency is about having a different neurotype from the more common or kind of baseline brain type, the neurotypical brain type. And determining someone's neurotype is often done by having a clinician observe and ask questions that help them determine whether the person has the more common or standard brain type or a neurodivergent neurotype. But not all clinicians are trained on how to recognize neurodivergency, particularly regarding autism. I know this is true among multiple neurodivergencies, but I read more of the research on autism. Most clinicians are trained to recognize it in white boys and struggle to diagnose when the person is not a white boy. So even if someone doesn't appear neurodivergent, such as by masking, they could still be neurodivergent. Many people are diagnosed as adults when they learn about the commonalities among certain neurotypes and recognize that they have that neurotype. So, you know, some of the other aspects of evaluations had more to do with determining where someone's skill levels are determined to be. But this is about when it comes to pursuing a diagnosis for, you know, whether someone might be ADHD or autistic or other neurodivergencies, since so much of it is based on what the clinician perceives, what they're able to see from the outside, and based on how they understand things to look, they can be wrong. And even if a person asks all the right questions, makes eye contact, you know, says the right things the right way with the right tone, and very pleasantly, you know, the clinician not recognizing that the person is neurodivergent doesn't make them not neurodivergent. They still are putting in all this effort. And so masking doesn't change their neurotype. It just changes whether or not somebody could see it. So common misconceptions after diagnosis. The assumption that if a person was not diagnosed as being a certain neurotype, then they must not be that neurotype. I've had parents before say, oh, I want to get him tested for autism so I know whether or not he is. And that can be great, right? And I do think evaluations should happen, but that's why sometimes I put a little bit more of the focus on recognizing where someone is frustrated or struggling, because we can't always rely on clinicians, whatever random clinician a person ended up with, to recognize a neurotype, even if it's right there, right? So if we can at least determine what areas need support, even if we're not able to name the neurotype, that's okay. And I am honest with my families of girls, of people of color, of bilingual families, that we may still need to support the areas where a person is struggling, even if they don't get the diagnosis. And not getting the diagnosis doesn't necessarily make it untrue. But if you're addressing the areas where they're frustrated or struggling, then you're at least giving the right supports, even if you don't have the name for it.
I'm smiling because you and I, Bobbi, have had this conversation previously in that too. And Elizabeth has had this conversation with me separately, that the books that we use as providers for criteria, such as the DSM and other books, they have like a checklist of criteria for this is what it means to live with autism. This is what it means to live with bipolar. And I feel like sometimes that's greatly lacking, whether it's from the community that the person is from or because of the age, such as like with bipolar, the language is actually written for adults. Do you come across a lot with that too, with autism, that the checklists that they have may not be sufficient to diagnose as well?
Absolutely. For instance, I had a client I was working with. She is a Gestalt language processor, which a person could be a Gestalt language processor, and I'll mention a little bit more about that in a minute. But you can be a Gestalt language processor and not be autistic, but she was a Gestalt language processor. She had difficulties with changes to schedules and routines. She initially had some difficulties communicating, particularly when there were changes to schedule or routines, very sensitive to loud noise and lights. So there were all these things, and I helped family recognize where the patterns were. They were providing the right supports, and started providing natural language acquisition support strategies. And so suddenly she started making these giant gains in her skill development because she was getting the right kind of support, and suddenly she was communicating so much better. But it was still stuff that had to be factored in. Is this a loud place? Is there a change to schedule or routine? Are we making sure to provide these supports? So these things were still needing to be considered. But it was only at this point that they got their screening for autism, and I had been working with them for several months, and the girl was used to talking to me over Zoom. She was fine with it, right? Like we would have a great time. So this person comes on the camera. She's not inherently scared because she's chatted with me a bunch. So she was friendly and things like that. And the person said, oh, she makes eye contact and she's friendly, so she's not autistic. So what about all that other stuff? Also, even with my sister, she was diagnosed initially as being severe or profound when she was 2.5, and then with the right supports had jumped up a lot in her language. And by the time she was 8, suddenly they were saying, oh well, we're not sure if she's autistic. She doesn't seem that autistic to us, right? And so it was like, are you saying that we could have done absolutely nothing and she would have ended up in the same place? Are you saying we shouldn't be giving any supports anymore? Just because it's not seen by the clinician doesn't make it not true. And that's why, I do try to prep my families that there's a chance that they'll get diagnosed with everything else, everything under the umbrella of something, and not get the umbrella, and
We get that a lot
kind of,
with our community. The children, we call it the alphabet soup, where
Right.
they will get every diagnosis except the mood disorder, or every diagnosis except bipolar disorder, as though cobbling together all of those different diagnoses will somehow be the equivalent of getting the one. So
right.
we see that a lot as well. I do have a couple of questions that have popped up that I wanted to make sure we got to before we finished. And so would it be possible for us to sort of let Bobbi finish up, and then we can do a little Q&A before we have to end?
I think absolutely. And we are nearly towards the end. And I just glanced at one of the questions and I have some resources for you that's going to answer it. So,
Okay.
Some other quick things that are common misconceptions after a diagnosis are the assumption that getting diagnosed with a neurotype means that the areas that made them qualify as that diagnosis needs to be remediated. So, for example, eye contact is not a thing that people need to worry about. And just in case anybody does, for people who don't make eye contact that much, many people report, particularly autistic people, feeling physical pain from making eye contact because it's an overload to the sensory system. And so, sometimes, for example, if not making consistent eye contact was found at the time of the evaluation as being one of the factors that contributed to an autism diagnosis. Again, it's not required, but it just tends to be the thing that people have heard about. Sometimes people think, oh, we need to teach eye contact because this was one of the reasons why they qualified. No, since this was diagnosed basically per observation, it was just their sign from the outside of trying to guess the neurotype that was on the inside. But even if you hid that sign on the outside, the neurotype would stay the same. So just because it was one of the signs that helped a clinician recognize the neurotype doesn't mean it needs to be fixed. It's just one of the ways they saw it. Same with social skills goals. Sometimes, for instance, a person, I don't know, info dumping being one of the things that came up as part of the assessment that might have led to an autism diagnosis. There are a lot of issues with social skill programs, and so they don't necessarily need to change something just because it was part of how they got diagnosed. Another misconception that often happens is the assumption that where a child is in their skill level upon diagnosis is where the rest of their life will look like, particularly with the levels used when discussing autism. In some of the research that's going to be in one of the links that you see towards the end of the presentation, whenever it came to the levels were made up. The levels aren't based on anything. I always have to let people know that because people think that the levels regarding autism is like some tried and true science-based. It wasn't. There was no research behind it. It's not based in anything. Now, autism existing a thing. Level 1, level 2, level 3, totally made up at the time of the DSM. There was nothing that backed it. But sometimes parents get this, oh, he's diagnosed level 2 autism, and they're imagining their life 15 years in the future based on which level they were diagnosed at. And really, there's nothing that backs those levels. It's just describing a moment in time based on how the clinician saw it. In the case with my sister, like I said, at 2.5, they diagnosed her as severe and profound. And, by 8, they were like, is she autistic? Probably not. And it was what the clinician said. She definitely is. And she also agrees that she is. But you don't need to imagine the rest of your life based on where a kid is at the time of diagnosis. Because that's scary for no reason. just give people support and you'd be surprised what happens. Anyway, so areas of support that are often overlooked, and then the next slide after this is resources. We'll be able to power through some of those questions really quick. Sensory needs, if a person is sensory seeking or sensory sensitive or a combination of the two, a sensory trained OT and SLP should help determine what that person may need to help them regulate. Proactive sensory supportive life, changing for many people. Gestalt language processing, if a person frequently quotes from movies, TV, or things people say, they might be a Gestalt language processor. Gestalt language processing is a type of language processing. It's a different order of language development. It's not bad. It is just a different order of development, and not all SLPs are trained in it. And so often they may test exceptionally high on tests, or they may test exceptionally low on tests, kind of depending on which test was being used based on their language development style. So seek out an SLP trained in Gestalt language processing. Again, not all SLPs are. Difficulty communicating either all the time or just when stressed. Language and communication support should be available, such as AAC. AAC supports communication and language development. It doesn't hinder it. Sometimes families are not given access to AAC for a long time because it's often used as a last resort due to cost or limited professional training. It shouldn't be. And there are many types of AAC available, but I do have one right here, and I'm only showing it to you because I have it as a link that people can use, so they can download it, so they can use it. I truly, particularly with my autistic clients, provide it to literally everyone, because research has shown nothing bad happens from having access to AAC. But if you're having difficulty communicating sometimes and you don't have access to it, it could be a problem. So there are words, I push a button, it said a word. That's an example. So there will be a link where you can use something like this that has these little folders, like these dinosaurs.
Allosaurus.
Kids really care about whether or not you get the names of the dinosaurs right.
Yeah.
I mean, there's a lot of other things in there too, but so those are my very quick side notes for areas of support that are often overlooked. And whenever it comes to schools, you can build them into the IEP. And whenever it comes to outside of that, you can just get supports with those. So at the end, and I am going to be sending this off to everybody, I do have some resources I frequently recommend. Every parent, every professional I talk to, I end up sending these resources to. Jennifer and Elizabeth have both received these, and I just send it to everybody. So it includes the link to the AAC that I just used. I recommend the Start Here guide from the Autistic Self-Advocacy Network. This is Gabriel's Making Sense of School, is a book for sensory needs. It's not specific to autism. Then there are some videos both about sensory autism and a few other things, and some additional books, research articles, and program. And here is where you can find me for future questions any other time.